Hi everyone, my name is Amer Zeidan. I'm a professor of medicine at Yale University, and I am right now in San Diego, beautiful weather here, where we are in the American Society of Hematology annual meeting. Very exciting abstracts looking at acute myeloid leukemia, and I have an amazing panel of experts and colleagues and friends in the field.
Hi, thanks for inviting me to join this panel. My name's Harry Erba. I'm at the Duke Cancer Institute in Durham, North Carolina.
Courtney DiNardo, really happy to be here. Thank you. I am at MD Anderson in Houston, Texas.
And Max Staff from Dana-Farber Cancer Institute. Yeah, thank you so much for joining me. So before we start talking into the main discussion about the new agents in acute myeloid leukemia, which we have actually some amazing updates during this meeting, maybe Courtney, you can start by overviewing the landscape of AML in terms of how we had this huge flux of new medications and how the choice of therapies is becoming more personalized rather than relying on the fitness of patient.
And I think, that could take an hour in and of itself. So I think what we need to recognize is that AML is just not a single disease, right? And we, for a long time, didn't have the genomic understanding and didn't have the treatment, availability to do anything other than, treat a young patient with intensive chemotherapy and try to cure them that way. And anyone who wasn't eligible for intensive chemotherapy got a hypomethylating agent for low-dose cytarabine. And so I think the first step was figuring out kind of the underlying genetics of AML and realizing that there are patients who do really well with intensive chemo and can potentially be cured. And there are people that really don't benefit. Fibers risk cytogenetics, P53 mutations, MDS-associated mutations don't respond as well. So kind of understanding that. And then the next step was all the new therapies, right? Since 2017, we've had a dozen new treatments, right? Some of them are smarter ways to give intensive chemotherapy. CPS, gemtuzumab, some of them are small molecules. Venetoclax has really changed the outcome for those older, more frail patients. But then there's just a host of targeted therapies that are increasingly available in this pie of AML, and we're realizing, we have FLT3 inhibitors for the FLT3 mutated patients. We have IDH1, IDH2 inhibitors. We have now menin inhibitors, right? The first approval for patients with KMT2A rearranged leukemias, but soon hopefully NPM1 also. So we have the ability now, at least in the relapse setting, to use these targeted therapies. And I think what we'll be talking about more is, how we can be improving even further and moving them into the frontline space in combinations to really curing more patients.
Thank you so much for this excellent